Greetings of the day, folks. Today we are going to discuss about fever and serious bacterial illness in infants and children. So let's dive in. So we are going to discuss in the sections of introduction, fever, and the causes, various foci like in lungs, UTI, or in the brain, or in the blood. Okay, and after that we are going to discuss about the treatment in a separate video lecture. So let's dive in to the topic proper. So the fever is the most common chief complaint of children presenting to the ED, accounting for around approximately 30% of the pediatric outpatient visits. It is critical to differentiate from mild and serious illness. Okay, so with fever, especially in the neonate and infants. This challenge is compounded by non-specific symptoms and lack of focus of infection in most children with fever. Many factors influence evaluation and management, including clinical assessment, physical examination findings, patient age, immunization status, and height of fever. This chapter focuses on the management of a neonate, infant, or child with acute fever at risks for serious bacterial illness because morbidity and mortality high if serious bacterial illness is missed or not properly treated. So neonates defined as infants less than 1 month old, right? So are at highest risk. And infants between 1 and 2 months are at highest risk due to relative immunosuppression. And the significance so will be discussed in the further sections. So fever, any elevation in the temperature above normal is commonly considered as fever. A cutoff value formally defining fever is not universally acceptable. In infants, threshold for relative concern has traditionally been 38 degrees or 100.4 degrees Fahrenheit. In the neonates or infant less than 2 to 3 months of age, temperature less than 36 degrees Celsius or 96.8 degrees Fahrenheit is equally concerning. Historically, occult bacteremia used 39 degrees centigrade or 102.2 Fahrenheit in those patients with 3 to 36 months, and a temperature more than 41 degrees centigrade or 105.8 degrees Fahrenheit was considered to confer increased risk of serious bacterial infection. So the cutoff is occult bacterium used at 39 degrees and 102.2 degrees Fahrenheit or 41 degrees is considered to increase risk of serious bacterial infection. So if the child is more than 36, source of bacterium can be reliably ascertained by specific signs or symptoms. In infants and younger children or children with developmental delay who have a limited ability to demonstrate specific signs and symptoms because of fever may be difficult to determine. Okay, so who have limited ability to demonstrate specific signs, it will be difficult for us to determine the source of infection. So the axillary temperature are zero point 0.6 degrees Celsius lower than the oral temperature, which are 0.6 degrees Celsius lower than the rectal temperature. The temperatures taken with an infrared are of variable reliability and reproducibility. The fever is treated with acetaminophen or ibuprofen dosages 15 mg per kg per oral or per rectal. Maximum dose is 80 mg per kg every 4 to uh, 6 hourly up to 5 times a day. Okay, 15 mg per kg is the dose and it can be increased. So acetaminophen can also be given IV with the dosages, intervals and maximum daily dosage differing by the age. The dosage of ibuprofen is 10 mg per kg, maximum dose is 40 mg per kg every 6 to 8 hours. Okay, so ibuprofen can be given to children older than 6 months of age. So it can be only to the patients, children to the mother. So serious bacterial illness. So serious bacterial in infants less than 3 months of age, and especially neonates are relatively immunodeficient, right? So neonates and infants demonstrate decreased opsonin activity. Decreased opsonization is a part where the macrophage engulfs the particles which are or the viruses which are coated with the opsonins. Okay, opsonins will be 3,3V and fibrinogen and other things, which makes the virus tasty. Like you can remember it as it will be tasteful for the macrophage and it will directly chew it out and it will gulf it. So decreased abstinent activity, decreased macrophage and neutrophil function, and bone marrow insufficiency. Infants and children demonstrate a poor IgG antibody response to encapsulated bacteria until 24 months of age. So immune development is a continuum and improves as the child matures, right? So therefore, the age of the patient and virulence of the bacterial considerations for the evaluation of the fever in the children and the identification of a serious bacterial illness. The most common manifestations of the serious bacterial illness in the child include UTI, bacteria, and sepsis and pneumonia, meningitis. Of note, the following discussion applies primarily to the developed countries, but so we'll see. So, urinary tract infection. Overall, the most common serious bacterial infection is UTI with or without pyelonephritis. The incidence among young children presenting to the ED with a fever with no obvious sources between 3 to 8%. In first 2 months of life, incidence of UTI is even higher. Okay, so in life, 2 months of life is even incidence of UTI is even higher. In a recent study, so UTI was found in 11% of infants who presented to the ED with fever and 7.6% among those with history of parent reported fever, but no fever on arrival to the ED. Because UTI may not produce symptoms other than fever, routinely they obtain a urinalysis and culture in the evaluation of febrile neonate or infant without other source. So additional details regarding the epidemiology risk factors will be seen after that. So it does not produce other than any symptoms. We must routinely obtain a urinalysis and a culture. Okay, so in one study 13% of the infants, like 15 of 117, less than 3 months of age with a febrile UTI admitted to the hospital had a sterile pleocytosis of the CSF, uh, thought to be due to systemic release of inflammatory mediators or low bacterial virulence in the subarachnoid space. A report by Pediatric Emergency Research Collaborative Committee in 2011 showed similar findings. However, another study did not replicate these findings. Less than 1% of the febrile infants with the UTI will have a bacterial meningitis, but concomitant and concomitant infection of the urine and cerebral spinal fluid has been reported. Okay. So we must be careful by seeing, and so the important points to remember here is, so patients with less than 24 months, the incidence will be 3 to 8%, and it will gradually, the first 2 months of life is even higher. And because the patient does not tell anything to us, we must try to get a urinary urinalysis and also routine urinalysis and also culture. And patients who might have a febrile UTI will be having a CSF, some sterile pleocytosis, might be due to the systemic release of inflammatory mediators. Okay, so this is how we must remember this. And next thing is the bacterium and sepsis. So patients, the febrile infants less than or equal to 3 months old cite a bacteremia or sepsis incidence of 1 to 3%. The most common causes of bacteremia in this age group are E. coli, Group strep, and Listeria. Okay, E. coli, Group strep, and Listeria. So most common causes: E. coli, Group B, and Listeria. Ill-appearing neonates or those identified as high risk because of laboratory testing have an incidence of serious bacterial illness of like 13 to 21%. Overall, however, viral infections are the most frequent cause of the fever in infants. Many studies have shown that infants with the viral illness are less likely to have a serious bacterial infection. Okay, so patients will be having these strokes, and ill appearing neonates or those identified as a high risk because of laboratory testing have an incidence of serious bacterial illness of 13 to 21%. Overall, however, Viral infection are most frequent cause of fever in infants. Many studies have shown that infants with viral illness are less likely to have serious. Okay. Most of studies of bacteremia or sepsis also cite the incidence of 2 to 3% in febrile infants 3 to 36 months. So prior to widespread use of heptavalent pneumococcal conjugate vaccine in 2000, a temperature of more than or equal to 39 degrees centigrade or 102.2 degree Fahrenheit with WBC counts more than 15,000 and absolute neutrophil count of more than 10,000 were independent predictors of occult bacteremia in febrile infants. And independent predictors of occult bacteremia in febrile infants and children between 3 and 36 months old. The presence of any of these factors increase the incidence of bacteremia to 8 to 17%. So what we must remember is, so patients with more than 39 degrees or more than counts raised more than 15,000 with neutrophil count more than 10,000 were independent predictors of occult bacteremia in febrile infants. Okay, the presence of any of these factors increases the incidence of bacteremia to 8 to 12. So, administration of a Haemophilus influenza type B vaccine, pneumococcal conjugate vaccine currently in use in United States is the 13-valent PCV and has decreased the occult bacteremia rate. Okay, to 0.5 to 0.7%. Incidence of serious bacterial illness in children 2 to 6 months old who are incompletely or not immunized not immunized decreased because widespread use of vaccines resulted in herd immunity. In 2009, a decavalent pneumococcal conjugate vaccine was released. Okay, so because of its okay, so there is 90% reduction in the infective rate. So given these declines and the fact that 80% of the pneumococcal bacterium resolves spontaneously, the traditional standards for routine evaluation of the febrile infant 3 to 36 months old have changed. Guidelines now recommend urine testing only. So, and also routine CBC and chest radiography are not indicated, and the use of routine antibiotics is discouraged. So, coming to the pneumonia and sinusitis, they are the most common bacterial infections of childhood, frequently associated with or following upper respiratory tract symptoms. Pneumonia occurs in all age groups, with most common causative agents being the same as those for bacteremia or meningitis in each group. Okay, so most commonly same, and most common causative agents will be being the same as those for in each age group. Incidence of pneumococcal has decreased since the introduction of pneumococcal conjugate vaccine. So, plain chest radiography remain the gold standard for the diagnosis of pneumonia. In neonates and young children, excuse me, routine chest radiographs are not necessary unless the patient has specific physical examination findings. First of pneumonia such as respiratory distress, rales, grunting, significant tachypnea, or in older children with chronic medical problems such as cystic fibrosis, congenital heart disease, chronic lung disease, or malignancy. Consider pneumonia and differential diagnosis of fever and upper respiratory tract symptoms. Even if there are no signs of lower tract infection, in one study performed before the widespread use of pneumococcal conjugate vaccine, a WBC count of 20,000 was associated with occult pneumonia. 19% of patients without focal findings. Without predisposing conditions for or abnormal test results, a decision to obtain a chest radiograph can otherwise be made clinically. Okay. So in older children with chronic like cystic Congenital heart disease, chronic lung or consider differential diagnosis of fever and upper respiratory tract infection symptoms. Even if there are no signs of lower tract infection, one study performed before the widespread use of pneumococcal conjugate vaccine. So WBC count of 20,000 was associated with occult pneumonia in 19% of patients without focal findings. Without predisposing condition or abnormal test results, this isn't often a chest radiograph can otherwise be made clinically. Pneumonia in a febrile but otherwise asymptomatic child is unlikely. Okay, so this is how we must remember this. So normally chest radiograph, and we must be careful in the patients with who have these findings, and the cause of the all symptoms will be same. And sinusitis is uncommon in patient children less than 3 because of sinus formation is incomplete. Okay, so meningitis, coming to the meningitis, develop one of most febrile illness less than cite a bacterial incidence of 1%. The most common organisms might be E. coli, group B strep, Listeria monocytogenes. For children more than 3 months old, most common organisms are strep pneumonia, Neisseria meningitis, and Staph aureus, and lower with a lower incidence of strep pneumonia meningitis because of vaccination, routine vaccination. So outside of North America, uh, epidemiology of meningitis is more complex, and depending on the region of the world, with which patients has been living or are traveling, Neisseria traveling. Okay, Neisseria meningitis and Mycobacterium tuberculosis are most common causes. And although Neisseria meningitis rarely occurs in North America, incidence may be higher elsewhere. So, especially with the meningitis built to sub-Saharan Africa. So, in patients with symptoms of meningitis and recent travel to Africa, meningococcal should be considered. Treatment is similar to other bacterial meningitis. Tuberculosis meningitis is discussed. Okay, so diagnosis is made by CSF analysis. Often, uh, you know, difficult to distinguish between viral and bacterial because there is a wide overlap in the CSF and peripheral blood findings. Because of the serious morbidity of the missed meningitis, administer appropriate antibiotics in the ED and admit any ill-appearing patient or any patient less than 2 months old with any degree of CSF pleocytosis. Infants with aseptic meningitis generally should be hospitalized and ensured adequate long-term follow-up because they are at high risk for dehydration and subsequent neurologic and learning disabilities. For older children with CSF pleocytosis and a likelihood of viral meningitis, if the child is to be discharged from the ED, it is wise to administer a long-acting parenteral like ceftriaxone 100 mg per kg IM or IV and ensure follow-up in 24 hours. So if we suspect aseptic meningitis or because they are at high risk for dehydration and subsequent neurological disabilities, so for all children with pleocytosis likelihood is so if they are child is to be discharged, it is wise to administer long acting one and should follow up in 24 hours. Okay, this completes our introduction. It is a long one, lengthy one. Sorry for disturbances in between. Hope you enjoyed the video. Thank you.